Dr. Sidhu, I think HOD sir has joined with the participants link. Is he around there, or should we help him with the panelist link?
No, I'm sending him the link, sir.
Okay, okay.
We'll promote him to panelist. Okay.
Yeah, please.
We can do it right here.
Sir, could ribbon introduce ಮಾಡ್ತಾರೆ. Camera on other. Just cursing. Just.
A very good evening and a warm welcome to a very educational webinar. My name is Siddharth Bhardwaj. I am the Senior Product Manager with Fish and Pickle Healthcare, and it gives me immense honor and privilege to welcome Dr. S.S. Kalyan Shettar, who is the Professor and the HOD of Pediatrics at the Sri B.M. Patil Medical College, Vijayapur, BLDE deemed to be university. With over 17 years of experience in teaching and more than a decade of experience in PG teaching, Dr. Kalyan Shettar is an experienced academician. Dr. Shettar has to his credit several journals as a reviewer and as an editor. He also has to his credit more than 30 publications, out of which 10 are international and 20 are national. Dr. Kalyan Shettar has keen interest in pediatric nutrition, intensive care, and infectious diseases. Thank you for having us today, sir. With this, I'd like to invite you to address and open the session.
Thank you, Siddharth. Am I audible?
Yes, sir.
Yes, doctor.
At the outset, I would like to thank Fisher and Paykel and IIP Vijayapur district to give me an opportunity to moderate this session. It's a very important topic on NIV in NICU and PICU. Last lot of interest has been created in the medical fraternity about the usage of NIV in sick children and adults as well. And during the pandemic, a lot of new introductions were there in the method of giving NIV. Lot of improvisation were done in the interface through which we are giving NIV. So to address these issues and the use of this NIV modality of therapy in neonates as well as sick children, we have got two panelists today. First one is Dr. Sidhu Charki, who is a neonatal intensivist working in our own college, that is BID deemed to be university. He's the lead intensivist working in the NICU. He has got a vast experience of last 5 to 7 years in the field of neonatology. We are really lucky to have him as the panelist today. He'll be briefing on the use of NIV in newborn babies. Over to you, Dr. Sidhu. Please unmute, Dr. Sidhu.
Not audible, sir.
Am I audible, sir?
Yes, you are audible now.
Thank you for your kind words, sir. I would like to thank IIP Vijaypura and BLD Deemed to be University for giving me this opportunity to speak on non-invasive therapy in neonates. I'd like to share my slides. Yeah. See, as we all know, we have two topics for today. One is non-invasive therapies in neonates as well as in PICU. PICU will be dealt by my colleague. I'll start with non-invasive therapy in neonates. Basically, the presentation will be in terms of history, introduction, mechanisms, delivering systems, evidences, and conclusion. As we all know, in 1891, Boehner E. started the concept of inhalation of oxygen in the newborn. You can all see those were the ventilators where the newborns were kept in. And in Dr. Boehner was a French obstetrician who wrote the first article describing the use of oxygen for premature infants, but Tarnier at 1889. What was the timeline of events? Basically, it's all started by using nasal catheter in 1907, whereas in 1919, Hill developed oxygen tent, whereas in 1920, we all started using oxygen for routine sick newborn. Coming to the introduction for non-invasive therapy, as we all know, preterm birth is one of the leading causes of death in worldwide currently. Since last few decades, survival of preterm neonates less than 30 weeks is increased because of the advances in invasive as well as non-invasive ventilation and surfactant therapy. Invasive ventilation, as we all know, is associated with complications like barotrauma, valve trauma, and biotrauma. Hence, the non-invasive ventilation came into picture. One of the main modes of non-invasive ventilation is nasal continuous positive airway pressure, which is a well-established standard mode of non-invasive ventilation, especially in preterm neonates. Basically, it also reduces extubation failure in ventilated neonates post-extubation. It is an established alternative to mechanical ventilation at birth in all neonates less than 30 weeks of gestation. This is the chart what we come across. I will be subsequently explaining in my slides this chart. There was a study in 2000 by Ramanathan sir, where we came into the concept that non-invasive ventilation itself can be used as one of the modes as primary mode of respiratory support. Basically, what we observed was the risk of lung injury or the bronchopulmonary dysplasia was quite high, and the risk of infection was quite high with invasive ventilation, whereas non-invasive ventilation basically reduced mechanical ventilation. It resulted in gentler ventilation and use of non-invasive ventilation. Why nasal CPAP is considered as a gold standard? Because there is a growing evidence of its safety and usage, and as because of the Quine and the supporting trial, we have been able to establish that it is feasible even in the smallest of the small babies. And there have been certain observational studies, including the Columbia experience, which has quoted nasal CPAP as the gold standard, thereby reducing the BPD rates in all neonates. This is the timeline what we are fighting currently. If we retrospectively go from 42 weeks till 23 weeks, which is currently we are aiming at, CPAP has been productive in terms from 26 weeks of gestation to 34-35 weeks of gestation, and still the work is on in terms of 23 weeks till 28 weeks of gestation. What is the CPAP mantra? What is the reason? How does it work? CPAP basically helps in opening the lung, thereby keeping the functional residual capacity. It keeps it open by minimal constant pressure, thereby resulting in least arterial trauma, barotrauma, and volume trauma. It also maintains the pulmonary arterial pressure at minimal levels, thereby reducing the ventilation perfusion mismatch. And as we all know, there is no ET tubes, there will be no biotrauma. The success in order to deliver a CPAP in a preterm neonate or a term neonate is we have to attain a stable and a desirable pressure, and it readily accepts humidification and supplementary oxygen at a desired temperature. Low resistance to breathing, minimal desk space, and it's a safe and a cost-effective method. It's easily understood by all the nursing staff and maintained and sterilized as well. Whereas we have seen instances where CPAP has failed as well. We call it as CPAP failure when we tend to intubate a neonate within 72 hours after putting on CPAP, or if the FiO2 requirement shoots up above 0.6, that is 60%. If we do a ABG where the pH is less than 7.2 and a PaCO2 more than 65, we tend to call it a CPAP failure. And as we all know, most of our residents would have come across this. If the Silverman score is more than 5 in any neonate on CPAP, we call it a CPAP failure. This is the image what we do in our unit. We can see the right hand side. That is a delivery room CPAP, what we use with neonatal resuscitator as such. And these are the various other modes which can be used to deliver CPAP. The second one, verbal CPAP, is quite common in our area, and continuous flow CPAP, which can be used with ventilator, and a variable flow CPAP as well. These are the various interfaces which we come across in CPAP. They can be binasal prongs, uninasal prongs, Hudson prongs, cut down ET tube, nasal mask as such. These are the various caps and other equipments which are necessary in order to apply CPAP in a neonate. And the most common problem which we discuss in day-to-day neonatology practice is the nasal injury amount which is caused because of the CPAP. There is a grading system for that. Stage 0, where it is intact and the no compromised skin, which you can see as on A. And stage 1 and stage 2 is nothing but superficial erosion. Stage 3, it almost results in necrosis of the full thickness of the skin, as seen in image 3. See, what we do in order to prevent nasal injury. Basically, we have to choose appropriate cannula size and apply a protective barrier by using a hydrocelluloid dressing and proper position of the interface at regular intervals, and use nasal skin assessment criteria in order to assess the injury per se, and try to reposition the neonate every 3 to 4 hours. If we start doing this, I can assure you that there will be a good quality improvement study in your unit in order to prevent the nasal injury. Coming, how do we monitor neonates on CPAP? We do monitor basic vitals like heart rate, respiration, and saturation. If there is any increased work of breathing, we assess in terms of Silverman-Anderson score. We do measure blood gas and chest X-ray at regular intervals based on the clinician's discretion. And if there is any run out of or secretions, anything, we need to take care of it. If the condition worsens, we tend to suspect pneumothorax, which is seen in around 3 to 6% of neonates on CPAP. What is the limitation? Basically, it causes two limitations. One is CPAP belly syndrome, one is pneumothorax, which is quite commonly, rarely seen if we use a proper application method. Coming to the evidence, what supports usage of CPAP as a primary mode of respiratory support in neonates? As we all can see in this forest plotting, it is favoring CPAP compared to HFNC as a primary mode of respiratory support in all neonates between 28 to 32 weeks of gestation. And this is one of our study which we did in Manipal in 2015, where we ended up quoting as nasal CPAP is the established gold standard for primary mode of respiratory support in preterm neonates in comparison to HFNC. And one more, which we did in BLD, our own university, here we observed HFNC with CPAP. At 5% level of significance, HFNC was found to be inferior compared to nasal CPAP with a 3.5% difference in the rate of failure. Basically, what I'm trying to say with this evidence is that CPAP is still considered as superior compared to HFNC as a primary mode of respiratory support in preterm neonates. And this is one more forest plot which says we are favoring CPAP compared to HFNC. Coming to the HFNC, my second half of the talk, HFNC is nothing but it's referred to heated, humidified, high flow, blended oxygen delivery into the nose via loose fitting binasal prongs at a flow rate of more than or equal to 2 liters per minute. This is a simple definition. If we understand each and every word of it, HFNC becomes really easy. Currently, HFNC is being increasingly used in many NICUs across whole world, including North Karnataka as well. How does it work? Basically, it washes out the nasopharyngeal dead space. It reduces the inspiratory resistance. It improves the pulmonary compliance, reduces the metabolic work associated with gas exchange, and also it improves pulmonary recruitment by positive distending pressure, thereby totally reducing the work of breathing. This is how basically it works. It results in unassisted breathing through optic flow method. Mechanism of action, as I earlier told, it results in a constant distending pressure, thereby reducing the functional dead space in a alveoli. Coming to the conditioning of air, as we all know, it is a heated, humidified, high flow nasal cannula. Humidification reduces the metabolic cost of air conditioning, thereby protecting the respiratory epithelium. Subsequently, the difference between in terms of mechanism of actions in CPAP and HFNC is CPAP is a closed system, whereas HFNC is an open system. And the correct prong size is the key for application of success in HFNC. The prong size should be 50% of the diameter of the nares. If it is not, it results in leaking around the nares. Thereby, the pressure required to be delivered is not attained. And this is one of the studies where we understand the flow set at 2 liters per kg. If it's a 1 kilo neonate, we start at 2 liters per se. What is the limitation? Basically, here the clinicians are not able to continuously measure the pressure which is generated by HFNC. It is unregulated, unpredictable, and it has got an interpatient and an intrapatient bias. Isolated reports of facial burns, subcutaneous emphysema have been reported in the literature till date. Basically, in our unit, we use in management of babies with mild RDS, post-extubation, slow to wean off to CPAP, chronic lung disease, post-insure technique, prevention and management of apnea of prematurity. That is what is our unit practice has been. Basically, I would like to quote it as primarily to use as a primary respiratory support in extreme preterm neonates, there is insufficient data till date. As a secondary respiratory support, we have got sufficient data with proven evidences. Coming to the interfaces, this is the most common question I've been asked in most of the talks which we do across. What are the interfaces you prefer, doctor? As we all can see, Ramsquenla is quite famous, but due to the non-availability, we have been using the Fisher and Paykel ones. As earlier quoted by me, the nasal prongs should be 50% of the diameter in order to deliver. These are the first generation, second generation, and the third generation nasal interfaces, what we have come across. If it's a preterm neonate, you can remember it's red color. For a neonate, it's yellow. And if it's infant, it's blue. And if it's a pediatric, it's green. Simple to remember for nursing staff as well. And these are the various cannula sizes which we prefer to use in terms of flow meter as well, and various classification in terms of that. What are the advantages of the oblique flow HFNC interface? Basically, it allows for natural facial movement, and when patients' cheeks are compressed, it improves the prong stability in the nostrils, and it is associated with easier readjustment and maintenance for caregivers. That is the best thing. Here, this is one of the pictorial depiction of how do we use in 850 system as well as airbow device. This is one more way of HFNC as well as CPAP, which can be given through either SLE or acute tronic. How do we set up? Basically, this is for all the residents and the nursing staff. We have to choose appropriate sized nasal prongs HFNC circuit, and we have to look into the pressure manifold. Basically, we start the air oxygen from 1 to 10 liters based on the weight of the child. We look into the temperature probe and the heat water adapter for humidifier. Look for water for irrigation. Minimal is 1 liter. And we have to take care of the clearing the airway tubings or oxygen tubings. Basically, the position to be tubing down and away from the baby, minimize fluid into the nares and the airway, thereby which reduces the risk for pressure injuries. Okay, coming to the monitoring, it almost is similar to what we do in terms of CPAP. Basically, we have to monitor for heart rate, respiration, and saturation, and look for any increased work of breathing in terms of Silverman-Anderson's curve. We also do blood gases and chest X-ray. Mind you, this is at the clinician's discretion, not regularly recommended. Basically, we also look for pneumothorax, which is quite rare compared to CPAP child. What is the advantage of HFNC over CPAP? If you ask me, it is associated with less number of air leaks, minimizes the nasal trauma when compared to nasal CPAP. And on HFNC, we have been doing successfully non-nutritive sucking in extreme preterm neonates, which has been difficult in terms of CPAP babies in our unit. And it optimizes the opportunities for parental care, including skin-to-skin contacts, breastfeeding. We have been able to attain around 80 to 90% of KMCs in all extreme preterm neonates. And the CPAP belly is comparatively less in HFNC neonates, thereby reducing the risk of abdominal distension and reducing any feed intolerance if it's involved. Okay, this is one machine which I came across around 15 days back. This was told to me by the HFNC team. This is FNP 950. It's a multi-dimensional machine. Basically, this humidifier can be attached to ventilation. It can be used to deliver CPAP. It can be used to deliver HFNC. It can be used to deliver oxygen. And the best point is it has got all the clear pictorial demarcation, what we can see in this slide. If you want a neonatal flow, it's set at 37 degrees Celsius, at 35 degrees Celsius, and 29 degrees Celsius. And it's invasive, non-invasive, mask, optic flow can be seen. And there is no need of using a temperature probe. And the ease of administration is quite easy. We have started using this in our unit as a demo right now. What is the take-home message from my talk is, as we all know, still date, CPAP is the established gold standard as a primary or a post-extubation respiratory support in preterm neonates as well as term neonates, particularly in preterm neonates of less than 28 weeks of gestation and extremely lower weight neonates, which are less than 1 kilo. population, there is a paucity of data to recommend usage of HFNC as a non-invasive ventilation mode. Most evidence is available for the use of HFNC as a post-extubation support, but not as a primary support. Use of CPAP in delivery room and transfer to NICU to be increased using neonatal resuscitator, which is not happening in most of the peripheral units of Karnataka. We do follow the principles of application and standard care to avoid nasal injury because of having a qualified nursing team. We train and motivate our residents and nursing staff in terms of usage of CPAP by doing regular workshops on CPAP through a trained personnel. Coming to the HFNC part, it has got a similar rate of efficacy to other forms of non-invasive respiratory support in preterm inwards, basically by preventing the treatment failure, death, or BPD. And the evidence is available for post-extubation support, but not as a primary support. And as earlier said, there is a paucity of data for less than 28 weeks of gestation. But I'm not going to say that you should not use it. We have been using in our unit for all the post-extubation units, and it is associated with reduced nasal trauma. The KMC rates are quite good, and skin-to-skin contact is quite good. And basically, the nursing staff or the residents, what they have to look for is the nasal prongs that has to fit 50% of the nares. Otherwise, the pressure delivered is not regulated, and you can't define it. And humidification is a must. And compared to all other devices of non-invasive ventilation, HFNC is better tolerated, and it has got the ease of convenience. Thank you. Over to you, Kalyan sir.
Thank you for the very nice elaborate talk. I have got a question. What is your experience regarding use of NIV mask for CPAP as compared to the nasal prongs?
Sir, in our unit, we have been using the NIV mask. With the NIV mask, with the interface, what we are been using, we have reduced the amount of nasal trauma, sir. The in between nostril trauma has been comparatively reduced. We did a QI study where we found that we could reduce around 30 to 40% of the nasal trauma by using mask instead of prongs, sir. And the ease of usage is quite good, sir.
Okay, the ease of administration is maybe we need to train our nursing personnel for use of NIV mask. Or,
yes. No, we would prefer masks, sir, compared to prongs.
Okay.
That would be quite easy as well, sir. And the only thing is we have to use a proper interface for nasal mask as well, so that the bridge of the nose is not injured, sir, rather than the nostril part.
Okay, well taken point. Are there any questions in the chat box from any of the participants?
They just look for questions.
Sir, if it's all right, could we take them at the end of the session?
Okay, surely. That will be fine. So I'd like to thank once again Dr. Sidhu. Be there for any questions which subsequently come in the chat box. Okay.
Sure, sir. I'll be there. Thank you, sir.
So the next talk will be by Dr. J. Prakash. He's a pediatric intensivist working in BLD deemed to university Department of Pediatrics. He has also vast experience of treating sick pediatric children, and he has been the backbone of our PICU for the last few years. Dr. Prakash will be dealing with the topic of use of HFNC in pediatric cases. HFNC in pediatric cases has been last few years, and the use has increased in adult population, I would say, with the pandemic. But pediatricians have been using this HFNC quite last few years. So over to you, Dr. Prakash, for the next talk.
A very good evening to all. At the outset, I thank FNP for organizing such a nice webinar, which is practically more applicable at this point of time, as we are getting more and more number of pneumonia cases and bronchiolitis cases. So my topic today is HFNC. So you have to share the slides.
Yes, sir. I'm going to share, sir. So my topic today is HFNC application in PICU. As everyone aware, in recent days, we have been using high flow oxygen in many of patients, which have given excellent results and outweighed the necessity of ventilation in the recent days. So that shows how important is the high flow oxygen. And Dr. Sidhu has already outlined about high flow oxygen prongs, things, and regarding the interfaces, different mask size, everything. So we'll go ahead. I'll be dealing on introduction, mechanism of HFNC, application in PICU, advantages, complications, and study supporting, and what will be the outcome. So this high flow oxygen nasal cannula oxygen delivery, mainly it is heated, humidified high flow nasal cannula oxygen, which is an effective form of non-invasive respiratory support, which we have been evidencing all these years. So we have been applied in many variety of conditions. It may be respiratory conditions, sometimes viral hemorrhagic fevers. We have been applied in the dengue fever. So mainly deliver high concentration of oxygen, and it produces distending pressure, which will help to maintain the functional residual capacity in the lungs. So thereby it helps in many of hemodynamics, improvement in the hemodynamics of the patient. And basically it is first introduced in the preterm as an alternative to CPAP. But recently, as we are all evidencing, it's been marked in increase in use of HFNC in pediatric and adult care. So mechanism of HFNC, there'll be connections like starting from the blended gas, where it goes to humidifier. From humidifier, interfaces will be there, and through that nasal prongs. The mechanism is mainly our airways will be mainly maintained with the dead space, which contains more of carbon dioxide. So when we keep giving oxygen at the high flow, so there will be reduction of dead space and clearance of the expired air in the upper airways. So that reduces rebreathing of the gas with high carbon dioxide and depleted O2. So it mainly increases the alveolar ventilation. And of course, it increases the dynamic airway pressure and increases the airway hydration, and it produces supplemental oxygen and reduction of dead space. So as we can see here, the nasal high flow and unassisted breathing. So there is a reduction of dead space with the application of high flow oxygen. And it delivers accurate oxygen delivery, whereas low flow oxygen will not deliver accurate oxygen delivery. So we can maintain the FiO2 in these children with HFNC. And airway hydration also it maintains, as we discussed. And these are the different types of prongs which will be applicable starting from the preterm to pediatric size. So for preterm, it is red color, and for neonatal, it is yellow color, and for infants, it is violet, and for pediatric, it is green color. So if we see here, this is the mean pharyngeal airway pressure recorded at flow rates of 2 to 8 liters per minute. And the diamond shape are the mouth passive, and round is the mouth closed. So just have a look at these figures. Is there any difference between these two, like mouth passive and mouth closed? So if you see properly, there is no much change in the pressure delivery. So the mouth leak is not much important. It is less important compared to nasal leak.
So how it is going to be applied in the PICU? So I'll go with the case scenarios which we had recently. So there was a 2-year child who presented with cough for 3 days, breathing difficulty, and he was restless for 2 days, so which got worsened since 1 day. So he had grunting also, he had chest retractions, he had bilateral crackles. And this is a child. So I'll just previous. Yeah. Sir, can I play the video? Call that person. Yes, the previous person.
So if you move the mouse in the video, it will have a play button.
The video. Yeah. So here you can have a look. So this is a child who is having breathing difficulty and he's restless, and which has got worsened since 1 day. Yeah. So what we could observe in this child is restless, and child is having grunting. You can able to hear, and he's having very bad chest retractions. And on examination, he had bilateral crackles. So it is found to be pneumonia. So we started HFNC in this child, and you can see the response after 8 to 10 hours. This is. Okay, so thing is the grunting has reduced and the tachypnea is still there, but it's better. Retractions have reduced. So the first application is, as we all see, in the community acquired pneumonia. So this is another child who is a 3-year child admitted with cough, cold, and breathlessness since 1 day, sudden onset, and the tachypneic. He had retractions, he had bilateral V's, irritable and distressed, and he had tachycardia also. This video is once he has been put on HFNC, it has been taken after 8 to 10 hours. Play once again. So when he came, we couldn't have time here. He had very bad respiratory distress and V's. So it got settled at the end of 8 hours. Yeah. So that is one of the application where we can utilize this high flow oxygen, that is acute exacerbation of V's, where it has given excellent results, and the children will improve over the 1 or 2 days. And one more child who is a 1-year child, history of wet cough and difficulty while feeding, and he has tachypneic, chest retractions, and bilateral crackles and V's. Diagnosed to have bronchiolitis. So this was child's X-ray, which showed the hyperinflation and infiltrates on the right side, as well as minimal infiltrations on the left side. So the high flow oxygen has been started with 12 liters per minute with FiO2 of 40%. After 12 hours, child showed remarkable improvement with decrease in respiratory rate and retractions. SpO2 became 100% with oxygen. This is one more child. Just have a look at this video. So child with severe pneumonia. Yeah, this was a child with severe pneumonia, ventilated for 5 days, and weaned to CPAP and TPs, eventually extubated, and he was put on HFNC. And after 1 day, we could wean off to prongs oxygen. So this has an application as a post-extubation as a weaning mode. So these are all the utilization where we can do, as we saw, pneumonia, V's, acute exacerbation of V's, and extubation, post-extubation. So this HFNC has got a lot of advantages, which Dr. Sidhu already has explained about these things. And mainly it has enhanced comfort and toleration. The child can be a little comfortable with rather than mask. So this will be nasal prongs. So child can communicate with the parents. So child can eat and child can look around. So child will be a little comfortable than mask. And simplified eating, drinking, and communicating and playing. So it gives continuous power for continuous therapy and reduced formation of mobile condensate, works with a variety of systems. So this one more, you can just have a look at this video. 2.5-year child, fever, cough, breathing difficulty. So this child actually was drowsy when presented, and it was moving only to painful stimulus. Child was tachypneic and had very bad attractions. So HFNC could not be tried on this child. As we can see, the child was very much drowsy and GCS was low. It was in shock as well. So HFNC could not be tried. So straight away we put on ventilator. So as we saw, at the same time, there are contraindications for HFNC, like whenever a child is having epistaxis, when child has basilar skull fracture, and when child has choanal atresia or nasal obstruction, where it won't deliver the proper pharyngeal pressures. And when child is having low GCS, in the absent airway protective reflexes, when child is in hemodynamic instability, this HFNC doesn't work. So I think we should go for the advanced airway in these conditions. At the same time, it has got a few complications. When it is unattended, when repeated examinations not done in these children with high flow oxygen. So there are chances of getting pneumothorax in these kids, especially when used for severe pneumonia cases, because lungs won't be that healthy. So there are very high chances that child can go for pneumothorax. That's the reason the utmost monitoring is very crucial in these children with HFNC. And of course, there will be gastric distension, which we can reduce by putting nasogastric tube. And the one thing is, like when we put the child on HFNC, the monitoring is, in fact, the monitoring required is more than the patients who put on ventilator. The ventilator, once we put a child on ventilator, we know the pressures delivered and we know the FiO2 things, and we can monitor through the ABG. But when we put the child on HFNC, so we won't be that keen and we don't know how much pressure child is getting. So we can make sure we think that child is stable, but in fact, the monitoring is more required when we put the child on HFNC. So sometimes there can be a delayed intubation and leading to hypoxia or other consequences. So that's why the delayed intubation, one of the very bad complications which we can expect. So the monitoring is very vital in children for which we put HFNC. So what we need to be monitored? We need to assess respiratory distress every half an hourly. And we need to monitor respiratory rate. We need to see the chest retractions, whether they are coming down or not. We need to see grunt, whether it is disappearing or not. And we need to monitor SpO2. And of course, the most important thing is consciousness. As long as child is consciousness, so we can continue safely HFNC. Once the consciousness level is coming down, it means that the child is going for respiratory failure, and where the failure rate of HFNC can be very high. So where we need to switch on to the ventilator. So this is one score which we routinely utilize for starting HFNC and for monitoring HFNC, that is Downey score, where it is scored from 0, 1 to 5 variables will be there: respiratory rate, sinuses, air entry, grunt, and retractions. So based on the values, so we see whether the score is coming down or is keeping high. So we expect the score should come down somewhere around 0 to 3. That's what our target. And the flow rate, it is 2 liters per kg per minute. So children more than 20 kg will take 40 to 50 liters per minute. Alternative formulas are like 2 liters per kg per minute till 10 kg, plus 0.5 liter per kg per minute for each kg above 10 kg, to a maximum of 50 liters per kg per minute. So that's the display of the high flow oxygen machine, where you can see the temperature and you can see the flow and you can see the FiO2 values. And the one with the round thing, that is a button start, and this we can decrease or increase the values. So once, if you go to studies, there are a lot of studies which have come shown the efficacy of this HFNC, and the one which has been published in New England, the Journal of Medicine at 2015, which shows that it reduces the mortality rate, it reduces the escalation of care. So thereby it helps a lot in children, in patients with severe respiratory distress. Yeah. And there was one more study in 2017 which showed that they have been enrolled around 620 subjects with HFNC, and which represented 27% of total ICU admissions. The primary indications being the status asthmaticus and pneumonia and bronchiolitis. So what they concluded was HFNC was utilized in 27% of all pediatric ICU admissions for a wide range of indications. Development of protocols for the initiation, escalation, and weaning of HFNC would optimize the utilization. And that's what they told. And one study was going on when I was in St. John's. So done by our chief, Dr. Lalita ma'am and Dr. Anjan. So who studied the predictors of success of high flow oxygen therapy in children with respiratory distress in PICU. So 114 children were treated with HFNC, 99 of them responded and 15 were non-responders. Decrease in heart rate, decrease in mean respiratory rate, and improving distress score at the end of 6 hours strongly correlated with response to therapy. And there's one more study on 2015 in Respiratory Care Journal, which showed associated with the decreased length of stay also it can be evidenced with the HFNC use. And one more in 2016, which came in the Journal of American Medical Association, which showed reduced escalation of care. So this is a thing which we have seen in our BLD PICU. So it's been implemented from 2018 onwards. So as you can see, 2018, 19, 20, 21, the usage of HFNC has been increased. At the same time, usage of invasive ventilation has come down. The picture itself shows that the efficacy of HFNC, and it has been widely used in variety of cases, many respiratory cases, which have given excellent results with less utilization of the invasive ventilation. So we could utilize non-invasive ventilation, HFNC, more effectively and reduce the use of invasive ventilation. And of course, it has been used for post-extubation care as well, as we do routinely here. And there are many studies supporting that, clinical evidence for high flow oxygen for post-extubation, starting from 2013 onwards. And one more thing is, like in 2020, in intensive care medicine journal, it's been come like they studied to guide clinical practice, evidence-based recommendations were developed regarding the use of high flow cannula in various clinical settings. And what results they got is 4 recommendations to guide HFNC use in practice. Strong recommendation for HFNC in hypoxic respiratory failure compared conventional oxygen therapy, and conditional recommendation for HFNC following extubation, and no recommendation regarding HFNC in the peri-intubation period. A conditional recommendation for post-operative HFNC in high risk or in obese patients following cardiac or thoracic surgery. So that's about my slides. If any queries, questions are in, welcome.
Very nice presentation, Dr. Prakash. I think in the chat box, few questions are there.
Yes.
So these questions, first to Dr. Jay Prakash,
Yes.
what are the advised flow rates in patients with bronchiolitis?
Yeah. So as at flow rates, as we have discussed, sir, till 10 kg, we take 2 liters per kg per minute. So for example, if a child of 10 kg.
Is there any changes depending on the pathology? Like the same flow rate will be in the case of pneumonia and the bronchiolitis as well, or there will be some difference?
Sir, we would prefer actually to keep a little higher pressures for pneumonia patients, whereas bronchiolitis, we tend to keep a little low pressures. And maximum, the formula only will be followed. If the pathology is not very extensive, we try to keep the lesser flow rates only, because we need to keep in mind about the complications associated with HFNC. If the lungs are not very bad, and if examination finding shows very minimal wheeze and all, we can manage these kids with very low flow rate itself.
And can we exceed the rate of 2 liters per kg, like 3 or 4 liters in any case, or will it cause any complications?
Yes, sir. Actually, it can cause, sir. Till now, we have not evidenced any complications, God's grace. Think if we have not exceeded any 2 liters per kg till now, sir. So that's the reason I could not answer, because we have followed the recommendations and we have stick to the rules. So I think that's the reason maybe we didn't get any complications till now.
Okay. One more question is there, like somebody is asking, like, advice in patients of post-oral surgeries if they are put on HFNC.
That's what, sir. I think post-oral surgeries, the delivery of PEEP may not be adequate. So that's the reason. Actually, in the children with facial surgeries or mouth surgeries, this is contraindicated, sir. In fact, the utilization of HFNC in these cases is questionable, as there is a loss of PEEP in these kids.
Okay, there are a few questions to Dr. Sidhu.
Thank you, sir. Thank you all.
Can you open the chat box?
Yeah. Use of HFNC in preterms or less than 28 weekers.
There are only 2 studies till now, 26 to 28 weeks, where they stopped the study because the feasibility was very minimal and the requirement of intubation was very high within the first 6 to 12 hours. So currently, there is no recommendation to use HFNC as a primary mode of respiratory support in any preterm neonates less than 28 weeks of gestation. CPAP is the gold standard.
Okay, one more question they have asked is it necessary to wean patient from CPAP to HFNC?
No, it depends on the underlying pathology. So if it's a chronic lung disease, if the child is able to maintain on HFNC, we would go for HFNC, because we have been using HFNC with KMC, sir. We are not able to attain in our unit doing KMC and CPAP together. For that, it depends on the clinician discretion, not necessary all the time.
I think the person who has asked the question confused whether weaning from ventilator to HFNC or ventilator to CPAP or CPAP to HFNC.
Okay. If that is a protocol, sir, it entirely depends on the underlying clinical condition of the child. If it's a 28-weeker, if we have followed INSURE, we end up going to CPAP, and CPAP can directly go to nasal oxygen depending on the FiO2 requirement. It's not necessary that from CPAP it has to go to HFNC, but if there is some amount of pressure requirement or FiO2 requirement above 30%, we tend to use HFNC in that scenario. For a term child post-extubation, moreover, we are preferring HFNC, sir, compared to CPAP.
Okay. So one more question is regarding the nursing care in HFNC for neonates. So some elaboration.
Yeah, I think that is the most advantageous thing the HFNC has got in terms of CPAP. HFNC is very easy to use. It is safe and feasible. It reduces the number of injuries. If we are trying to use one HFNC prongs for one child, if we fix it once, it can't be moved for next 72 hours. And the best part is we can use with a huge prongs distance. We can use it easily for KMC. We can do breastfeeding. We can do NNS on that. And the nursing care with minimal injury of nears is possible with HFNC compared to CPAP, sir.
Okay, there is one more question. Both can answer. Is there any protocol when decreasing the rate of HFNC, the flow rate?
Yes, sir. There is a protocol. Actually, because the slides were more, I had to delete that slide. If it's below 10 kilos, we gradually reduce the flow rate by 1 liter to attain a minimum flow rate of around 2 liters per 2 liters. Then subsequently take out from HFNC. About 10, I think Dr. Jayaprakash can take a call. I think it's the similar. What you're
similar, I think. So we'll keep same. 0.5 will start from 10 kg onwards.
Reducing the flow rate by 0.5 liters per kg. Sir.
Yes.
Per kg. Till the minimum.
The baseline is 2 liters, sir. The baseline is 2 liters.
2 liters after that. Okay, so more, I think, more usage of HFNC in older children will make life easier for even the intensivists, because less monitoring is required as compared to the ventilator therapy. And even the caregivers like nursing staff, they are also find it easier to use as compared to the ventilator.
Yes, I would say just add one point, sir. Monitoring will not change, sir. In fact, we need to monitor very closely per se, because these children tend to go for respiratory failure. So monitoring equally requires till 4 to 5 hours. So we can, in the 4 to 5 hours, we can able to make out whether it's giving positive results or it is not giving.
So in the chat box, there are no more questions as such.
So sorry to interrupt. There's just one more question that's come on chat. Somebody is asking, can we use ROX index in neonatal and infant HFNC?
Can you come again, sir? Can we use?
ROX index.
No, sir.
ROX index.
No. Still, we are preferring the SAS scoring system per se. And there are 8 studies to come on that, sir.
Kalyanchita sir, you can go ahead. I think there are no other questions.
Okay, thank you. So I would like to thank both Dr. Sidhu and Dr. Prakash for giving a wonderful lecture on CPAP and HFNC use in neonates and pediatric population. It has been a well conducted seminar, this one. CME, I think all the budding pediatricians, postgraduates, and they must be finding it very useful for them. In the participant list, even I saw many of the senior pediatricians like Dr. Koturesh, name was there, and many other senior persons have also attended this talk. I thank them for attending this on behalf of IIP Vijaypura and the Fisher and Paykel. Once again, I thank Fisher and Paykel for taking this initiative to conduct this webinar. Thank you. Thank you, everyone.
Thank you all, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you so much, sir. Thank you.
Camera